Good morning, good afternoon, and good evening, everyone. Thank you very much for joining us today. My name is Erta Kalanji, and I'm a research fellow at One Health Trust. We only have 1 hour for this discussion, so this introduction will be to the point. Our discussion today will focus on fungal infections and the burden that they impose on our health and well-being. While severe fungal infections are rare, compared to the uncomplicated superficial ones we usually, or most of us are familiar with, they can be deadly as well. And in the backdrop of climate change, a growing population, and the increased risk for future pandemics, this is a very important issue to discuss, and they cannot be ignored. The reason for that being that currently we are not well prepared to diagnose them and treat them. So for the past year, we have been talking to experts from different fields, and we have discussed some of the gaps, the challenges, and the opportunities that arise to address them. And some of these experts are here today, and I want to thank them in advance for their dedication and their support. So joining us today, we have Professor Malini Capoor from Vardhaman Mahavir Medical College and Safdarjung Hospital in India. We have Professor David Denning joining us from the University of Manchester in the United Kingdom. We have Dr. Ana Alastruey Izquierdo from the Instituto de Salud Carlos III in Spain. And we have Dr. Hatim Sati from the World Health Organization. So thank you again for taking the time to speak with us today. Before we start the discussion, I just wanted to go over a few practical information. We will spend the first 45 minutes having a discussion and highlighting some important issues with experts. We obviously are not going to be able to cover everything, but we will have about 10 to 15 minutes at the end of this webinar to answer some of your questions. So if you do have them, please add them to the Q&A section in the Zoom app. Often they get lost in that you can ask. We'll also share a few relevant articles or reports that will complement the discussion today. So we look forward. I look very much forward to this discussion, and we'll start right away because the time is passing. So we'll start with Dr. Capoor. Dr. Capoor is joining us from India, and she is a professor in microbiology and a leading expert in mycology. Dr. Capoor, thank you for joining us.
Thank you, Erta, for a gracious introduction. Hello, everybody. Greetings from India. Yeah.
And greetings from Ivory Coast. That's where I'm based. And just to let you know, in general, our audience today is very international. And I can say that there are many countries represented here today. As I mentioned earlier, fungal infections, they can differ greatly in the way they present and in their severity. And many of them are considered rare and neglected diseases. But during the COVID-19 pandemic, this rare disease, also referred to in a popular form as the black fungus, was responsible for thousands of cases and deaths. So there were several outbreaks during that time. Can you tell us how this played out? What is this disease, and why were there so many deaths in India during that time?
You're absolutely right, Erta. Fungal infections, they differ greatly in presentation and severity from superficial to deep-seated and angio-invasive fungal infections like mucormycosis. And even in cases of superficial fungal infection, you take the example of dermatophytosis. If there is irrational use of steroid, it can also land up in epidemic proportions, what we had in great Indian epidemic of dermatophytosis. But, we all know that mucormycosis is the third most common invasive fungal infections. But during COVID-19, there was an unparalleled upsurge in mucormycosis cases in India, especially during the second wave of COVID. To be precise, that was from April to July 2021. In fact, it was a tsunami, more than a deluge, I would say, although the concern about mucormycosis in India is not new if you compare the pre-COVID data and during COVID. But during COVID, it was, 50,000, more than 50,000 cases. To be precise, it was 47,000 cases as per the Government of India website, and it clearly mentioned that the cases could be more. And India, we know that it is the diabetic capital of the world, second, you could say that. And but it was mainly the uncontrolled diabetes, which played, and the misuse or the irrational use of steroid, that was the factor. The factors are well known, whether it is uncontrolled diabetes or hematological malignancies, neutropenia, solid organ transplant, burns, trauma, and immunosuppressants like corticosteroid therapy, and non-adherence to the infection control practices. These are well known factors. But if you compare, the pre-COVID data of mucormycosis from the Indian healthcare facilities, how it increased, and this increase was due to increase in the interventions. Then that was the pre-COVID data, how from one particular tertiary care center from 24.7 cases annually, it increased to 3 times. That was pre-COVID. And then if you compare the Indian prevalence, it is 70-fold greater than that of the global prevalence. And during COVID, as I've already mentioned, during the second wave, that was from April to July, there was a tsunami of cases, 47,000 cases of mucormycosis. And diabetes, I would say it's poor control, hyperglycemia induced by steroids, and because a large number of COVID-19 patients were taking other prescriptions or the over-the-counter drugs also, glucocorticoids, immunomodulators, unsupervised due to the excessive caseload, which likely contributed to the epidemic. And we are all aware that corticosteroids, they are used in the management. They can lower the mortality in individuals with severe disease, especially in cases of oxygen shortage. And Government of India also, due to oxygen cylinders shortage during the second wave, there was a guideline when to use, but there was irrational use of steroids because of increased caseload. And but everybody is aware that steroid, it acts as a double-edged sword, it impacts the neutrophil migration, endocytosis. And the COVID-19 and its treatment also may accelerate the cellular development of COVID-19 associated mucormycosis. There are certain protein receptors like the spore coat protein COTH present on mucorales. They initiate the infections by binding to the endothelial receptors. And these receptor expression is raised by the host variables, especially associated with diabetic ketoacidosis, ketone bodies, high glucose concentration. And there was a, uncontrolled diabetes and steroid-induced hyperglycemia, which led to this epidemic. And there are large number of studies from India which support that. Even study from our center also supports it was irrational use of steroids and immunomodulators due to excessive caseload. And already our public healthcare, facilities, they are loaded with patients. And India is heterogeneous as far as the topography is concerned, and the healthcare facilities, we have the best of the centers also. Then we have the primary healthcare centers also. There's a study with Reference Center and other centers like Muthu et al. In 2023. And they also corroborated that it was the uncontrolled diabetes, then hyperglycemia induced by steroids. Few studies have quoted zinc supplementation also. Basically, it is COVID-19 steroids and COVID-19 per se steroids, and the hyperglycemia induced by steroids, and the uncontrolled diabetes mellitus, because people were not visiting the hospitals during that time. And then the government of India also declared it to be a notifiable disease. And already there is a low doctor-patient ratio because our population is quite high. And the COVID-associated mucormycosis prevalence was 0.27% amongst the hospitalized patient. So I would end the discussion like by the unholy trinity of diabetes and the rampant and irrational use of corticosteroids and over-the-counter availability of these drugs amid COVID-19, especially during the second wave, our caseload was very high. It was next to USA and appears to increase the occurrence of mucormycosis. And though the concern about mucormycosis is not new as far as India is concerned, but during the second wave, it was deluge, Thank you, Ota.
Yeah, thank you so much for getting into the details and the specifics of how the COVID-19 pandemic created the perfect storm for the outbreak of mucormycosis in India. Given the challenges or the issues with diagnosing fungal infections and the lack of access to healthcare where the burden is highest, this may be the tip of the iceberg in India. I just wanted
Exactly. Yeah, because we are a tropical country and, our spore count is also very high, the indoor and the outdoor. And then we have overburden clear because of population, the healthcare system. And then already there is, there are a lot of other rare fungal infections also coming up. And yeah.
So it is clear how something that is rare can be not rare anymore, not rare no longer, if I can say that. But what implications does it have for future pandemic? And do you think that India is ready? Of course, it is difficult to address all the issues that are there, but with regards to this particular outbreak, has how is the country prepared now, and what kind of implication does this have for future pandemics?
Yeah, Government of India, after this pandemic, it has created 7 Indian Council of Medical Research Centers of Excellence in Mycology, apart from the 2 WHO recognized or the ECMM recognized centers we already have. That is, one is at PGI Chandigarh, the other one is at Patel Chest. Already 7 centers of excellence, referral centers for mycology are there in the various zones of India. And then the government of India also developed a portal that was created at the National Centers for Disease Control, that it was linked with the Integrated Disease Surveillance Program. It made the mucormycosis notifiable. And then in the as per the National Medical Council also, there's a pandemic module added to the curriculum of the medical graduates and the postgraduates, wherein the 5 common fungal infections we were teaching them the theoretical aspect of the common fungal infections, but they have also now stressed upon how to diagnose, especially the second-year undergraduate medical student. After studying microbiology and the fungal infections in detail, they've been asked to diagnose, especially when they're posted on the clinical site during their medical school, like in the ENT posting, that is otolaryngology posting, they have been asked how to diagnose a case of mucormycosis, invasive aspergillosis. So 5 diseases they have taken up. One is aspergillosis, where the disease burden in India is high. Aspergillosis, cryptococcosis, mucormycosis, and also dermatophytosis. They are asked to teach how it appears on the microscope and how they can diagnose, because especially when these medical graduates, they practice as part of their internship program or the rural posting program in the outreach center, they are able to diagnose on the microscopy aspect, the basic facility aspect. And then there are certain India-specific guidelines, which are nothing but the ISHAM and the ECMM guidelines, which have come up, the fungal infection study Forum is there. Then the ISMM Society for Medical Mycology is there. And the Indian Council of Medical Research, they have come up, Ministry of Health and Family Welfare. And the fungal infections, they are in focus. Like everybody knew that fungi, they have been surviving this earth since billion of years. They have survived the asteroids, they have survived the pandemics also and played havoc during pandemics. So, and they are important part of climate change. So now Government of India is also focusing on fungal infections and have added to the medical and the undergrad curriculum, the practical aspects, the management part of it, and has opened the centers of excellence for diagnosing it further, apart from the two WHO and the ECMM recognized center.
Okay, thank you
So
so
that,
much.
you know, the clinicians and the microbiologists, they act as a team, they work in a team and for better diagnosis and management of fungal infection. And one good thing has happened is the WHO essential diagnostic list has come up, wherein there are lateral flow assays for the 3 common fungal infections in India, like cryptococcosis, aspergillosis, and histoplasmosis. And, you know, then the government also has a plan of, you know, initiating these tests in the centers across India. So this thing good has happened, and especially these kind of webinars One Health is taking for better, you know, awareness about fungal infections, and a lot of clinicians and microbiologists have joined around the world.
Thank you so much,
Thank you.
Dr. Capoor.
Yeah.
Thank you so much for your very detailed insights. I think for the sake of time, we are going to, I know there's a lot more to say, and thank you for sharing the from India. We're going to move on to Dr. Denning. Dr. Denning, thank you so much for joining us today.
You're welcome. It's a pleasure to be here.
Spent his entire career working on global health and medical mycology, and he's the founder of GAFI, Global Action for Fungal Infections, who not only brings awareness on these infections, but also advocates for access to diagnostics and treatment for everyone. So thank you so much again for joining us. I'm going to start by saying I will highlight the issues with diagnosis, where during our earlier conversations and roundtable discussions, somebody said that fungal infections exist where there is a mycologist. I thought that was very well said and interesting saying. So they are hard to diagnose and hard to treat. Could you please highlight some of the most important unmet needs in the clinic regarding both diagnosis and treatment? Where are we today?
Sure. So fungal infections generally, there are some exceptions, are less common than bacterial and fungal infections and viral infections. And therefore, it's very easy for people to sort of ignore them and think that they've done a good job because they've recognized a virus infection, they've treated with antibiotics, and many patients will get better, and that's great. The problem is that many of these fungal infections are lethal if they're not diagnosed and treated. So it's really important to, even though they're less common, to pick them up and to treat them. And it's made worse, that problem, because they're often co-infections. So you can have 2 things together or 3 things together. And so it isn't just using Occam's razor with, if you've diagnosed, you know, E. coli, therefore you can forget about everything else. You can have E. coli and Candida, or you can have tuberculosis and histoplasmosis, or they can be mistaken. So there's an issue of co-infection and mistaken infections. So the real way to focus this, and I'm going to leave out of this discussion skin infections because that's a separate topic area, is that it's mostly the patients at risk that need to be studied in detail. So those are the patients in ICU, the leukemic patients, patients with cancer undergoing chemotherapy with strange syndromes, funny lungs and pneumonia, who may have pneumocystis or aspergillosis, patients on dialysis, diabetic patients, late-stage HIV patients, and patients who aren't getting better from tuberculosis, patients with asthma that's poorly controlled despite doing the normal things of giving them some steroids and steroid inhalers. So there's a discrete group of at-risk patients, and they're the ones that need the diagnostics. If you're in an emergency room and you have a child that comes through the door who's a bit sick, that's not a child that you would normally do a fungal diagnostic on. But all these other groups, of which there's quite a lot of people, those are the ones that really need the care. And the challenge for us is where of the health system those things sit. So in Africa and other parts of the world, patients with HIV may present for the first time in a local community clinic, and they don't have the ability to diagnose cryptococcal disease or histoplasmosis or pneumocystis in many circumstances. So they'll often infer the patient as TB because that's relatively common, treat the patient for TB, and then by the time the patient has arrived at a hospital, the local hospital or a teaching hospital, which it may be too late to save them from the fungal infection, which is actually the primary problem that they've got. So one of the great needs here is where to do these tests and where in the health system do they fit. And my view is that all of the WHO listed essential diagnostics should be available in all teaching hospitals in every country across the world. That should be just absolutely, completely and utterly routine. If you call yourself a teaching hospital, you need to be able to diagnose fungal disease, come what may. And then there's a dialogue about a bit further down the health system in the bigger district hospitals, which tests are appropriate in that setting. And microscopy is cheap and easy, and that should be available everywhere, in my view, and fungal culture should be available everywhere. And some of the more sophisticated tests like cryptococcal antigen should also be available in those types of settings. So I think that's what we should be aiming for. We have been so blessed in the last 15 years with a wonderful set of new, relatively rapid, relatively inexpensive, and pretty high-performing diagnostics for fungal disease. The best is, of course, cryptococcal antigen lateral flow assay. That's a fantastic test. But there are many others that are pretty good as well. And they just need to be factored into every health system and be used. And then alongside that, the education and laboratory education and clinical education alongside that.
Thank you. Thank you so much, David. What about with regards to the development of new antifungals and treatments that are currently available? It is difficult to design new antifungals because of many biological and other factors, biological factors and other ones. But with regards to one of the later stages of development, clinical trials, could you please highlight some of the issues? Because I think that that's a very important sort of step to be discussed, given how we consider these diseases to be rare, and they may be rare in some populations and not in others. And so how does this complicate the development in the later stages of drugs development?
So we've got, we have a reasonable portfolio of current antifungal drugs, but there are some countries that don't have them, and that's the first problem. It's not what you've asked me about, but it is important that before one starts developing new things, that at least the old things are available everywhere. We need new drugs because we've got quite a lot of resistance in antifungal. In Aspergillus, there's quite a lot of azole resistance. We've got Candida auris, which is a multi-drug resistant Candida infection, and often Candida glabrata is resistant. We've got organisms that are intrinsically resistant, such as Fusarium, just poorly responsive to many things. So we do definitively need new antifungals. And we also have underperforming antifungals. So if you give fluconazole for cryptococcal meningitis, only about 1 in 3 of your patients will be alive after 6 months. That's inadequate therapy. It doesn't work very well. If you give amphotericin and flucytine together, you can push that up to 60 or 70% response, but it's not 100%. So how do we get to 100% or 95%? How can we rise up to that level? And that's where the new drugs come in particular. So historically, these drugs have been licensed for invasive candidiasis or candidemia and invasive aspergillosis. There hasn't been a new registration for cryptococcal meningitis or histoplasmosis for 3 or 4 decades. We haven't seen a drug that's come through for those other areas. So they tend to be developed just for Candida and Aspergillus infections. And then the other infections sort of get added on. Maybe it's got activity on this, and so the little study is done. And so the confidence about how these drugs actually work in these other settings is not so great. And to prove a drug is safe and works, you've got to study probably 1,000, 1,200 people with the new drug. And that's after you've got through all the difficulties of preclinical and phase 1 and all those things. And then you've got to show at least equivalent efficacy. And that's quite difficult to do. And superiority is particularly difficult to do in statistical terms. So these studies are big and expensive and complex to do. The groups studying cryptococcal meningitis across the world, groups, I should say, have been remarkably successful at raising public funding, but that's the only fungal disease where public funding of significant amounts has been put in to do randomized controlled clinical trials. And we need public funding, I think, for some of these other infections to be able to study them. Fungi and humans are sort of fairly similar. We're all eukaryotes. Finding the exact target within the cell that kills a fungus and doesn't kill a human is a little tricky, but there are lots of targets to do that. In fact, that's not the primary problem. I think it's taking them from there all the way through to the end of clinical is actually what the biggest challenge is. And I would really like to see some real good public funding and some really good clinical trial networks for these other diseases coming through.
Thank you so much, David. And I think you sort of prepared the way for our next topic, which is antifungal resistance. And for that, we have Dr. Alastruey Izquierdo joining us from Spain. Thank you for joining us today. A lot of your research has been focusing on antifungal resistance. Could you tell us something about it? How does it differ from... Yeah, you pretty much you have everything on the go. Yes.
Yeah, so thanks very much. First, can you see my screen?
Yes, we can see it. Thank you.
So thanks very much, Herta. I'm very, very happy to be here and to be with such a big audience. So I would like to use this opportunity to say as a remark some of the things that my previous colleagues have said. So one of the problems is the lack of diagnosis, but whenever we have a diagnosis, how do we treat the patients? So we only have mainly 4 classes of antifungals available. These are polyspidimidines, azoles, and echinocandin, and most of them have different problems. So not only toxicity, because as you know, one of the problems is that fungi have eukaryotic cells, the same as we have. So that's why it's one of the reasons why it is difficult to develop new antifungals, but they have drug-drug interactions. Sometimes you need to do TDM to check that the level of antifungal in the body, wherever the infection is happening, is correct. Some of them don't have, they are only IV treatment. For example, the echinocandins, they are some restricted, as David was saying. The problem is that even if they are good and you treat the patient and they are not responding very well. So just to give a couple of examples, David has touched on this already. So there is now in the last years emergence in antifungal resistance. It was first with azole-resistant Aspergillus fumigatus started to be a problem, more like in 2008, and we've seen that the increase in azole-resistant fumigatus has been enormous in the last years, and you can see it all around the world. But also, as David was saying, there has been also development of echinocandin resistant in Candida glabrata, which is a pathogen that is usually already high or resistant to azoles, so that limits you with mainly only amphotericin B to be able to treat this species. And lately, in Candida auris, that has been a pandemic, It's been appearing in all different countries. It causes nosocomial infections, very difficult to treat, as is the first candidate that is pan-resistant. There are isolates that are pan-resistant to all antifungals. And including, there are many other intrinsic resistant fungi as Fusarium and other species. We've seen that there is not much data about that because luckily we are still not in the ranges of antibacterial resistance. So there's not that much rate of resistance, but we don't want to get to that, right? So we want to act now that we can and that we see it raising and that we can do something. There's not that much data, but some of the papers that have been published show that whenever you have a resistant strain, the mortality increase a lot. So susceptible strains, the mortality could be between 30 to 50%, while 88% in this resistant strain. This is just an example. And you can also see how the use of antifungals in the clinic have an impact in the epidemiology. So what you would say, and I like this very much, because what you would say you would see here is that when you have the epidemiology, the species, because you know that fungi are all over the world. When you breathe, you are breathing fungal spores. They are on your skin, they are on your mouth, on your nose, on your intestinal tract. They are everywhere. So whenever you treat with an antifungal, the same as it happens with an antibiotic, you change the community that you are having there. So if you treat with more than 7 days, you have a different epidemiology and you will have different species. And this completely relates with the pattern of resistance. So it's very important to do antifungal stewardship, a control which antifungals you are using. And we are only talking about the clinic now. I think we can talk about the One Health approach later, but this is more or less what I wanted to say on this regard. Erta, you're on mute.
Apologies. That is a very important point because antifungals are not only used in the clinic, they are widely used as pesticides in the agriculture. And could you please elaborate a little bit on this connection between the two and if there is an impact?
Yeah. And as I knew you were going to ask this, because that's we are now facing a real One Health challenge here. So while in other places there is not that, and maybe some fungal infections are not that, but fungi are mainly pathogens of plants. So most of the fungal infections that we know are in plants. So we use fungicides everywhere in the world to try to not develop these infections in the plants. So they are used everywhere. And we've seen that the fungicides that are used in the agriculture are very similar to the ones that we use in the clinic. And the resistance has been cross-resistant. So it has been demonstrated that the use of fungicides in agriculture develops resistance in the environment that is able there to cause infection in the clinic. So a real One Health thing. So there has been two routes of antifungal resistant development in Aspergillus fumigatus. One is the use of fungicides in the agriculture, and also long treatments in the clinic. And an important thing there is also that we've seen that in the environment, we have very big hotspots. If you think about fungi, where would you find fungi? Well, whenever you have humidity and you have some worm. So this is a perfect storm when you do the compost in the environment. Whenever there is agricultural practices, if they are full of fungicides, the earth, so they is full of fungicides, then it's warm and it's humid. So that would be a completely overgrowth of fungi that they are with the pressure of the fungicide. So they develop this resistance, then they produce spores, and these spores are everywhere. Everybody inhales them, and if you are sick and you get sick and your immune system is not working properly, then you can develop an infection.
Thank you, Anna. That's incredible. Thank you very much for these slides. I think we're moving along really well with them. I'm sure that there are a lot of questions that we can address later on, but we'll move on as well with Dr. Sati, who is joining us from Geneva. He has done some very important work at the WHO with regards to the fungal priority pathogen list, which came out last year. Now, this has been a very important development, as the list was the first of its kind. So in addition to bringing awareness to the issue, it also has identified some specific gaps in the field. So Dr. Sati, thank you for joining us, and perhaps you could talk about some of these gaps that you identified.
Thank you, Erta. Thank you, colleagues. Thank you for having me. Indeed, as you mentioned, the last major exercise to prioritize fungal pathogens, we conducted over 2 years with the participation of a broad range of stakeholders and experts on this call. Anna and David were crucial to the completion. Anna is the chair of that working group. And through that process, we were able to identify a lot of gaps in terms of knowledge, in terms of evidence. Perhaps the most glaring gaps were related to the extent of the burden of fungal infections, both the fatal and non-fatal burden. And this is related to a number of challenges highlighted by the previous speakers. David spoke about the nature of fungal infections being common yet not identified and picked and diagnosed in clinical practice, because often they are co-infections or misdiagnosed or missed altogether. A lot of the patients are immunocompromised, and in many countries, the patient that passes, that case is never closed in the clinical terminology, as in the definitive cause of death, the definitive diagnosis is in a lot of settings is not identified. That makes it hard to really gauge the burden of fungal infections. There are a number of other factors also that contribute to the complexity of this burden. There are challenges that are highlighted by Anna, for example, in terms of the One Health aspect and the use of antifungals in the environment. This is the tip of the iceberg, the evidence that we have now, and I think more evidence is emerging and needed. There are more evidence needed to also understand the role of global warming in terms of impacting the distribution of some of these fungal infections, the severity of them, as well as the overall ecology of these pathogens. So there are a number of issues there that needs to be addressed, and we were hoping through this report to highlight the importance of these deadly pathogens, this largely neglected area. The goal here is to draw the focus and drive, hopefully, investments into research, basic research, also innovation and research and development of new treatments, expansion of access to existing treatment and diagnostics in an affordable fashion. And David highlighted the importance of access. In many countries, major centers don't have access to basic mycology diagnostics, as well as even the limited number of classes of antifungals. One more area that we are hoping through this report and the upcoming work that we will be doing is to also drive some investments into the research and development of new antifungals and the optimization of existing treatments. Also, David touched on the need for optimized treatment and more effective treatments, diagnostics. And again, antifungal resistance is an area that also needs a lot of attention and a lot of work. The speakers before also touched on this idea of funding. Here, funding is a major challenge, as it is for research and development of all anti-infectious diseases. The area, just in general, is not attractive to investors, and that creates a need for the collective to address this through public funding. And we, through our work, are trying to raise the profile of fungal infections, and especially the resistant fungal infections, and to include it in the discussions in different forums that focuses on the prevention and control of antimicrobial resistance globally. We believe that eventually the solution to these, for lack of better term, broken market dynamics is for governments and member states to allocate funds to improve governance and commitment to address these important areas. Lastly, I want to just touch also on the importance of public health interventions. And that includes also the importance of education and integration of this area of work into curricula, into medical training. Our colleagues who've been doing this for a long time and who've traveled and assessed situations in different countries tell us that there are glaring gaps in the trainings, in the knowledge, which leads to also a lot of these infections being undiagnosed, and leads eventually to a lot of patient suffering and unnecessary deaths and costs also in terms of the economic burden. Over to you.
Thank you, Hatim, for this really important points. These are great recommendations, but considering the epidemiology of the disease worldwide, as well as the fact that different countries have progressed, at different stages with their progress to implement or address these issues. How would you suggest, how could we, what would be the recommendations for countries to adopt these global guidelines at the national level?
So I wouldn't first characterize the report recommendations as guidelines just yet. And this is the next step of work to be done. We have been in deliberations, and we have plans to have a stepwise approach at all three levels of the organization to address this issue in a coordinated fashion, as we do with many disease areas. Some, of course, will need to be addressed at the global level. So at the regional and the national level, we are in close coordination with our colleagues in the surveillance teams, as well as our colleagues who are focused on what we call the global diagnostics initiatives. These are two areas that aim at strengthening and building capacity at the country level for surveillance of disease, AMR, including fungal diseases, and also focused on ensuring access to quality diagnostics where it's needed, specifically to inform patient care. The approach is, of course, being taken in a patient-centered fashion. As David earlier mentioned, to treat a patient, you need the knowledge. To have the diagnostic suspicion, you need a diagnostic tool, but also you need access to affordable care and treatment to treat your patient. So also we're working in coordination with relevant teams in the essential medicines list and in essential diagnostics list, specifically the discussion around what it means for a drug to be in the essential medicines list for a diagnostic test to be an essential diagnostic test. And that is what David again touched on that when he said there needs to be the drugs and the diagnostic tools in these lists need to inform procurement. Financing should be put behind these procurement schemes to ensure steady supply. Issues, of course, globally, there are a number of global issues around supply chain and drug production. That is a whole area of discussion. But all of these areas are challenges that needs to be addressed, and we are working. I must say, it feels that it's moving, but I think it should be moved faster, and we are determined actually to keep on pushing on this topic in collaboration with, of course, partners and colleagues who are focused in this area.
Thank you so much. I think we have a bit of time to address or answer some of the questions. I see that some of them have already been answered in the chat. A question open to perhaps David, Dr. Denning, or anybody else in the group. So one of the questions is about vaccination. So briefly, is there a perspective for vaccination, especially for candidosis, which is the most common and invasive fungal infection?
No, is the answer to that. There aren't any fungal vaccines. There's the technical possibility of doing one for pneumocystis, but there wasn't an economic case that was possible. Aspergillosis is more complex because you've got invasive, chronic, and allergic disease, so you've got to get those different types of disease sorted out. And there was a vaccine developed for Candida, and it was trialed in women with recurrent vaginal candidiasis, and it was partially effective, but then it wasn't taken further. One of the difficulties with candidiasis is knowing who to vaccinate before, ahead of time. So you may know that about a transplanted leukemic patient, but many of the patients who arrive in ICU or have dialysis or renal failure are not known ahead of time or don't respond very well to vaccines. Dialysis patients respond poorly to vaccines in general, for example. So the answer is there isn't a vaccination strategy for the world at the moment, and there are no companies that I know of any size that are working on it.
Thank you. I also see a few questions that have been answered in the webinar. So I'd ask, for example, the question about the difficulties of developing antifungal drugs and vaccines to refer to the chat, because there are some very good links there. But when it comes to antifungal resistance, Anna, maybe a very quick answer from you. Many people, when they think about antimicrobial resistance, they sort of associate it with antibiotic resistance. Now we're talking about antimicrobial resistance, which also includes antifungal resistance. And these two may be different. If they are, could you just elaborate a bit? How does antifungal resistance differ from antibacterial resistance? I don't think many are aware of this difference.
So thank you, Erta. Yes, I think it's important. One of my main goals in the last months in all the meetings that I've been, it's saying whenever somebody says antibiotic resistant, I say antimicrobial, because I think we have to use the momentum and to use all the advocacy that all the people from antibacterial resistance has done, highlighting the importance of this fact. To use it for antifungals. As I was saying, we are not in the same stage in a way that antifungal resistance is not as high rate as it is with bacteria. And one of the things that is influencing that is that first, antifungals, systemic antifungals are not usually sold in the counter as frequently as antibiotics. You know, you use antifungals to treat sometimes nail and cutaneous infections, but that could be a problem in some places. And we know from India that azoles are sold around the counter. But one of the main differences with antibiotic and antifungal resistance is that, as far as I know, and up to now, there is no horizontal gene transfer in fungi. So in bacteria, you can have a bacteria in your body that has a resistant mechanism, and that through a plasmid can be transmitted to other bacteria. So this is a horizontal transference of genes that are resistant. In fungi, this is not such a big problem yet, because the genomes, the fungal genomes, are more complex and have a different way of developing resistance. So resistance is usually happens through the continuous pressure on a specific strain or a species. But we also have another point in fungal infections, which is that there are emerging species that are intrinsically resistant. That means that, as we were saying, Fusarium, Pseudosporium, Lamentosphora, all these species that are included in the priority list, they are intrinsically resistant to all antifungals. So that's something. And one of the things that I think is important when we compare antibacterials and antifungals is that, despite saying that we have a very limited number of antibacterial drugs and in the pipeline, they are not such a development, in antifungals is really ridiculous. So we have mainly like 9-10 different antifungal drugs. And in the pipeline, there is like 4 or 5, much better than in the previous decades, but still not enough, because we have some things that are not covered with the current situation. So in a way, we need to be aware that although it's not such a big problem as it is with the antibacterial one, we are in a point in which we can act, and we need to do surveillance. We need to investigate the research and do research in the mechanisms and the drivers of antifungal resistance. We need to understand a lot. We are far behind antibiotic resistance. And that's why I think we should use the antimicrobial world to be able to cope that.
That's a very, very good point, because despite this lower risk for acquiring resistance from this horizontal transfer, when you talk about fungal infections, they take longer to treat or require a lot more. They're more complicated to treat than most bacterial infections. And then you have also previously mentioned clinical resistance. So, that comes from all these challenges.
And I think there are only two points there. One is like, whenever we say that fungal infections, it's always after discarding bacterial and viral infections. So it's usually already delayed. So that's one point which makes it difficult to treat the patient. And on the second hand, we don't have really good antifungals. As David was saying, even if this strain is susceptible and you get levels of the antifungals to the infection or whatever, mortality is still high sometimes. So we really need to do better.
Thank you. And I'm picking up a question that perhaps could benefit everybody in here. A question from Justice Danso. Are there platforms that focus on education and training clinical or research personnel on diagnosis and identifying infections? Do such platforms exist?
I think, to my knowledge, there isn't a specific sort of research training program per se, but there are loads of resources. So the Mycosis Study Group runs webinars, the Asia Fungal Working Group runs webinars, the ISHAM runs webinars. There are multiple congresses held in this area. We run the live fungal education online, which has got a lot of videos attached to it, which include how to do specific tests in the lab. There are other major resources, the Asperger's website, the ISHAM website's very informative, the Gaffey website's got a lot of information on it. So there are lots and lots of resources, but a lot of that is self-learning rather than being taught in a format, if I would put it that way.
One final question. I believe it's for Dr. Denning. What would be the most cost-effective tool for diagnosis of fungal infections? And also, are there any new innovations?
Yeah. So microscopy is, if you have a positive microscopy, then you've got excellent evidence of infection. But you have to have the right sample. And many patients, particularly respiratory infections, don't ever produce the sample, so you can't do it. And it's insensitive. So you'll only pick up depending on what the topic area is, 20%, 50%, maybe for cryptococcal meningitis, 80%. It depends on the thing, but it's never 100%. So it's cheap. It does require some skill. So probably in broad cost-effective terms, microscopy is absolutely core to any mycology laboratory. Fungal culture is inexpensive, but it's also not very sensitive. So for aspergillosis, it's about 30% sensitive. Candidemia, invasive candidiasis, is about 40% sensitive. So you've got insensitivity of culture, but culture is really important because you can define exactly what the fungus is, and you can do a susceptibility testing test. The best test is probably cryptococcal antigen, but of course, cryptococcal disease is not that common. So if you're working in, I don't know, in Belgium or Netherlands, you can do loads and loads of tests and none of them are ever positive because the disease is so rare. So you need the cost effectiveness depends on the frequency of the disease underlying it. And that therefore will vary by the different clinical setting in which you test. And there isn't a single test. It does require multiple tests. It also requires being able to take the right sample, bronchoscopy or corneal scraping or a lumbar puncture. It also requires radiology as well. You can't, for particularly pulmonary sinus brain infections, you can't do that without radiology of some sort. So this is it can be, doesn't always, it can be a complex area of medicine, and people do need good training. But the answer to the question is no, there is not one single test that does it all.
Thank you so much. And with that answer, we are just 1 minute over the hour. Thank you very much for joining today. We'll close the webinar for today, but I see that there are some comments about having access to the links and some of the materials that we've shared here in the chat. If you'd like to have a list, please contact us on the contact email that came with the invitation. So I'd like to thank our speakers today for taking the time and devoting their time to such an important topic. And we look forward to future webinars and more activities that bring awareness to fungal infections. So thank you everyone for joining, and have a great day.
Great. Thanks. Okay.
Thank
Bye.
you.
Bye, thank
Bye.
you.
Bye. Bye.
Bye.